Good morning, everyone. My name is Joy Brady, and today I will be presenting a proposal for my project entitled Use of Deep Learning for Tracking Metastatic Sites of Prostate Cancer over Time from PSMA-PET Imaging. I'd like to begin by thanking my supervisors, Dr. Jake Kendrick and Dr. Martin Ebert, for their support and expertise over the past few months. And I look forward to conducting some meaningful research with you over the next year. So I know you just heard about prostate cancer, but bear with me. We'll start with some background. So the prostate is a gland found only in males that produces some of the fluid that constitutes semen. Prostate cancer begins when the cells of the prostate gland begin to grow out of control. It is the leading form of cancer in Australia, with about 26,000 cases diagnosed last year. And it is the leading form of cancer globally for males, making up about 28% of cases. Metastatic prostate cancer is when the cancerous cells originating in the prostate gland dissociate and spread by the blood and lymphatic system to other sites of the body. So the most common sites of prostate metastases are the bones, the lymph nodes, the lungs and the liver. However, brain and other organ involvement is not uncommon. As you can see from our PET scan, on the bottom right, metastatic prostate cancer is characterised by a high lesion burden and vast tumour heterogeneity. The prognosis for localised prostate cancer is actually quite promising, with 96% 5-year overall survival reported, but about 20% of cases metastasise, after which the prognosis dropped significantly to only 36% 5-year overall survival. Essentially, what I hope you take from this slide is that prostate cancer has a significant impact and prevalence globally, and so ongoing research into improving patient outcomes is vital. In terms of imaging of prostate cancer, PSMA-PET has proven to be the gold standard. So prostate-specific membrane antigen, I'll say that once and only once, is a transmembrane glycoprotein that is significantly overexpressed in prostate cancer cells relative to normal cells, which allows for specific imaging of cancer cells with high sensitivity and specificity. The prognostic value of PSMA-PET is well recognised, with the aggressiveness of disease reflected by PSMA uptake. Because of this prognostic power, there have been several frameworks that have been developed to define disease progression with respect to a change in lesion size or shape, or the appearance of new or disappearing lesions. So these include the PSMA-PET progression or PPP criteria and the response evaluation criteria in PSMA-PET CT or RECIST frameworks. Lesion tracking has proven to be a powerful prognostic tool. It involves corresponding lesions between two time points, and from there you can determine whether a lesion is growing or shrinking, or perhaps whether new lesions are forming or lesions are disappearing, which can then be correlated with disease progression based on these frameworks. So you might be wondering what the point of my research is. I thought I'd demonstrate in a fun little interactive way. So we'll go back to our PET scan of our metastatic prostate cancer patient, and we'll pretend that this is a scan taken at baseline. And then we will take another scan 6 months later following therapy plus standard care. And I will pose the question to you all, was this treatment effective? Now, I'm a little time poor, so you don't get much time. You'd probably say right off the bat that no, it wasn't, and you'd be correct in saying this, but would you have any confidence in telling a patient this? Would you tell them that their disease is stable, that it's progressing, or that it's getting better? Now, I can tell you that based on the PPP framework, this patient actually has progressive disease characterised by the presence of 2 new lesions, but I only know this because I drew them in. So if I hadn't drawn them in, I probably would not have been able to say that with any confidence, and it would have taken me a very long time to correspond these lesions between these 2 time points. So obviously this is quite a crude example, but I think that it demonstrates the point. So for these exact reasons, manual lesion tracking is very seldom, if ever, undertaken in clinical practice because it's highly labour intensive, it's very inefficient, and it's also subject to inter-observer variability and random human error. So what is there a way to automate this process to make it not only more efficient, but actually more accurate? Enter deep learning. So the potential of artificial intelligence in medicine and its capabilities of improving patient outcomes is well recognised. Today, machine learning is the most relevant subset of AI systems in medicine. However, deep learning models are increasing. The prevalence of deep learning models are increasing with improved computing infrastructure and capabilities. There have been many studies into the potential of deep learning algorithms in all aspects of the cancer treatment process. So with respect to lesion tracking specifically, we've seen an advancement from semi-automated methods through to the emergence of artificial intelligence and machine learning, and then more recently, deep learning models. So here I've listed the 8 most notable studies that I identified during my systematic review. During my review, I found quite quickly that this is quite a niche topic. There's not a whole lot of research into automated lesion tracking, particularly in the case of PSMA-PET, which is great for me, but it also meant that I needed to kind of expand my search to include more archaic methods of lesion tracking across different cancer types and also in the application of PET and CT. Interestingly, there were quite a few studies into lesion tracking in CT, but not as many in functional imaging modalities. So that's quite exciting for my research because it means that we can apply these techniques to a functional imaging modality that can potentially give different or more robust information in terms of disease progression. So all of these studies identified the challenges in longitudinal tracking and the need for further research into clinical validation of such methods. As always, the availability of a substantial volume of high-quality variable data is a hindrance in machine learning applications, particularly in the medical field. So while we're seeing algorithmic performance improving with these methods, there have been very few studies that have convincingly demonstrated the clinical implementation of these methods. One study that we identified as kind of the benchmark in terms of performance was Deep Lesion Tracker, which was proposed by Jinseng Kai et al. In 2021. As you can see, the Deep Lesion Tracker architecture is a complex 3D Siamese network that contains 2 identical convolutional branches that processes baseline and follow-up images in parallel. The model utilises traditional techniques of rigid and deformable registration, as well as learning-based registration methods to correspond lesions between 2 time points only. The model was trained and tested on a very large data set of 3,891 lesion pairs from about 4,500 patients with a diverse range of cancers. So obviously this is a very large and diverse data set, which was very uncommon in all of these studies, most of which were conducted on a small cohort with one particular or maybe a few particular types of cancer. The model was also validated on an external data set of 536 lesions from 100 patients from a different institution, which alludes to its high generalisability, again, very uncommon in these studies. In terms of performance, Deep Lesion Tracker demonstrated 88% accuracy in locating lesion centres, with 5% improved error when compared with leading registration methods. The author notes that in the overall tumour monitoring workflow, the performance of the model was comparable to human performance. But perhaps the biggest advantage of Deep Lesion Tracker would be the time-saving factor. So Deep Lesion Tracker is said to run 14 times faster than registration-based methods on whole CT volumes, which is a huge clinical advantage. A limitation of this study was that the model was trained and tested on only CT images, so potentially could limit its application in functional imaging modalities such as PET, but that's where my research comes in. So my research aims to develop a deep learning model for tracking metastatic prostate cancer lesions between baseline and follow-up in PSMA-PET images. In order to do this, we'll utilise a fully labelled ground truth dataset of 337 scans from 256 patients with metastatic prostate cancer at both baseline and follow-up. The scans are full-body Gallium-68 PSMA-PET CT scans that have been segmented semi-automatically. So that means that they've been segmented automatically at first and then corrected by a nuclear medicine physician if necessary. And the lesions have also been manually corresponded between baseline and follow-up. Very luckily for me, ethics approval for use of these images has been prior granted to Associate Professor Rosalind Francis of the Department of Nuclear Medicine here at Charlie's back in 2023. So very happy days. Perfect. So the first step of my research, as I mentioned, will be to test Deep Lesion Tracker on our data set to see how it translates to PSMA PET scans. Luckily for us, the Deep Lesion Tracker model and the entire Deep Lesion database is actually available for public use. So there should be no issues with access there. And the next step would be to develop our own deep learning model for automated lesion tracking, with the hope being that Deep Lesion Tracker will provide the foundation and we can just fine-tune the model from there to improve its performance in PSMA-PET. The next step will be to develop a software that can take the output of the model and then give some qualitative or quantitative measure which we can then assess. So the intention would be for the model to track the lesions between 2 scans, and in doing so we'll be able to identify whether there are any new lesions or any disappearing lesions, and the software can take that information and then make a classification based on either the RECIST or the PPP framework or both as to whether the disease is progressing. that then leads quite nicely into the final step, which would be to evaluate the performance of the model. So one way in which we can do this is to evaluate performance in terms of how accurately the software replicates the response metrics compared to those that would have been obtained manually by the nuclear medicine physician. Obviously, another way of assessing performance in a model like this would be to go through and check that the lesions have been corresponded correctly. However, I think given that the study aims to improve clinical implementation, I think the accuracy in disease classification is probably a more valuable performance metric. And so I'll give a brief timeline of events. So I've now completed the proposal, presentation and literature review. So we'll get started in February of next year by testing the deep lesion tracker, as I mentioned. And then a majority of the time will be spent developing the deep learning model and the software, and then allocated some time towards the end to evaluate the performance and explore other clinical outcomes and future works. And then from about mid next year, we'll look to complete the thesis and prepare my final presentation. And so a key controversy in the application of AI in medicine is the so-called black box nature of AI. So deep learning models being trained to come to conclusions without giving any indication of how they've reached their decisions. And in a medical setting, that can prove problematic for clinicians and for patients when there's no transparency, which is understandable. So I think that all future research into applying AI in medicine should focus on just explainable methods to achieve appropriate clinical translation and reliability of the model. So in the context of PSMA-PET, an explainable technique could highlight which features of a lesion the model is focusing on, or could explain how and why a model identified changes in lesion boundaries. And that could then give some sense of confidence that the model is accurately identifying features of the lesion, which can then give confidence in the decisions that are being outputted. And so there are a few future kind of directions that this research can go in. So obviously this model is quite specific in that it is solely for lesion tracking, and even in the response metrics that it's outputting, it's more for the evaluation of the performance of the model as opposed to giving like a clinically relevant prognosis for a patient. So future works could consider extending the model or implementing it in an extensive software that can then combine multiple techniques. So for example, our model is for lesion tracking, but we already have a fully automated segmentation model that's been developed by Jake Kendrick et al. That can perform lesion level detection with high accuracy and high sensitivity. So, for example, as a software that combines both models would have the capabilities of tracking lesions and then subsequently segmenting them. And you could look to further extend that to include feature extraction, radiomics, etc., to then provide a more robust prognosis for a patient. Similarly, we could look to, for future works, could look to implement an algorithmic means of extrapolating the output of our model across multiple time points to then provide longitudinal tracking across the entire treatment process, as opposed to just baseline versus follow-up, which is kind of a limitation of our model. So a few future directions. I have allocated some time to explore these within the thesis, but I think it's a bit unrealistic to have that as an aim. So to summarise, this study aims to develop a deep learning model for tracking metastatic prostate cancer lesions between baseline and follow-up in PSMA-PET images. As mentioned, lesion tracking is a powerful prognostic tool, but manual lesion tracking is very seldom undertaken as it is labour-intensive, inefficient and subject to random human error and inter-observer variability. So we aim to utilise advancements in artificial intelligence to improve the efficiency and accuracy of this technique to then allow it to be implemented more routinely in clinical practice. This offers significant benefit to both patient outcomes and clinical practice and has the potential for even further development. Thank you for listening. I hope you enjoyed. Any questions?
Thanks, Julia. Any questions from someone other than me? Yes.
That was a great presentation. I just wanted to ask about the deep learning architectures.
Yeah.
Have you had a look at what potential architectures you might look at, or like transfer learning from the deep lesion matching thing?
No, to be honest, not quite. I'm very new, for those of you who don't know, I'm very new to deep learning, so that's why I've allocated quite a lot of time next year to the development stage, because it will be a learning process for me as well. But yeah, as I mentioned, the hope being that we've got access to the deep lesion tracker model, so we can just fine tune the model from there. How that will happen, I will get back to you on that one, but yeah, that's the hope.
Are you planning to extend your work to other lesions in the future?
Sorry?
Yeah. Are you planning to extend this work to other lesions instead of?
Oh, absolutely. The hope is that the model can then translate to other forms of cancer, other lesions. But we're just starting small for now, just get it started on one. And then, yeah, future works would absolutely consider extending it to other imaging modalities, other types of cancer.
And also.
Yes, absolutely.
Yeah, thanks a lot. Yeah, I just had a question about, do you know if the deep lesion tracker in the study, because they're talking about like the number of lesions that were missed, like talking about the lesion, yeah, trying to test on like lesion pairs, on lesions, like, do they give them patient level metrics or like the number of, yeah, more like how well performed with the patient level?
As in like what types of lesions and.
Yeah, more just like say given the patient has like 100 lesion pairs.
Oh, yeah.
And what percentage for this patient, like say what percentage correctly match?
Oh, I don't believe so. I think from my reading of the paper, it was more general performance. I don't believe it had specifics at a patient level, but can definitely look into that further.
Yeah, because I mean, do you think that'd be important in your case to like ensure that you bear in mind like splitting the
I think so. I think it's always important, like if it performs really well on a case or a person that's got 2 lesions as opposed to a metastatic case, that's going to impact how it then works on our data set, because our data set is all patients with metastatic prostate cancer. So yeah, definitely would have an impact, but I suppose we'll see when we start testing the model how it translates.
Joel, Tio has a question. Tio?
Yes. Thanks, Riley. It's really interesting. I was just wondering, quick question. Do you know if in the ground truth annotations, the correspondence between lesions between baseline and follow-up, is that information only regarding new disappearing and corresponding lesions? Or is there also information regarding lesions that may have split or merged during treatment?
I believe the lesions in the data set have been matched between baseline and follow-up. So all like corresponding lesions are indicated in the data set, which is great.
Oh, okay. Yeah. Awesome. Thanks.
I do have a quick question. So I was just wondering, with the manual methods of lesion tracking, is there any data on inter-observer variability for that? In terms of how much 2 observers can differ between tracking lesions between 2 scans?
I haven't looked into the actual numbers, but there is significant inter-observer variability in lesion tracking, I believe.
It would be good to have that quantified, because then that tells you, it gives you a sort of benchmark performance.
Absolutely.
If it's within that range, then it's no different from just getting or observing.
Exactly. Yeah.
Match the
Jake?
Yes.
Sorry, just to comment on that, I found one paper and they showed there was about 67% variability between multiple observers, especially in cases where the tumor burden was above 30 lesions on the scans. I can share the paper maybe. But
Yeah,
it was
if you don't mind, that'd be great. Thanks.
Yeah.
I was actually going to say about, I think 30% rings a bell. So yeah, 67 is massive.
Yeah.
Okay, that's all the time we have. Thank you, Julia. Well done.